Welcome back. This is ECG Primer 4. In this session, we will be dealing with the ST segment changes. So first we have to define what we're basing the ST segment changes on, and we're basing it on the J point. So the J point is the transition between the QRS or depolarization and the ST segment or the repolarization. And it's the inflection point at the end of the S wave. So that's the last negative deflection of the QRS and the beginning of the flat portion of the ST segment. So wherever we have the inflection point, that's the J point. And we compare that to the preceding PR segment.
So in general, the QRS and the ST segments are concordant, which means they point in the same direction. So what's happening here is if you have a functioning conductive system, it doesn't take very long for the entire ventricle to depolarize, more or less instantaneously or quite quickly. So what it does, it comes to the bottom and just kind of reverses itself and repolarizes in the opposite direction. So you have the two processes occurring in the opposite directions, and they're of the opposite electrical sign. So these two negatives cancel each other out, and they produce deflections that point in the same direction on the EKG leads.
Let's look at this example of a normal EKG. So if, for example, we look at lead 1, we see that the QRS is positive and the ST segment is upright as well. This follows in leads 2, AVL, AVF, and then in lead 3, which is isoelectric, actually the ST segment is flat. The leads that are negative, like AVR, also have flipped T waves. On the 3D, so the precordial leads, it's a little bit more complicated than that because we're adding vectors in 3 dimensions and they don't quite follow those same rules. But if you look at the lateral leads like V5 and V6 and V4, they follow those rules. The anterior ones, V1, V2, V3, not so much, but we'll talk about that in more detail later.
And as we mentioned when we talked about a left bundle back in Primer 1, hypertrophy and conduction problems make the QRSs and the ST segments discordant, which means they point in the opposite direction. And this is happening because of the increased muscle mass or because the conduction system isn't working. Now it takes a very long time to depolarize. So now by the time that the bottom of the heart is depolarizing, the top of the heart has already started to repolarize, and it continues to repolarize downwards. So now I have depolarization and repolarization going in the same direction, but because they're of the opposite electrical signs, they produce opposite deflections. The effect is more pronounced for conduction blocks than for hypertrophy, and it's more pronounced for left side rather than the right because there's simply more muscle mass on the left, so any effects will be more pronounced on that side.
So let's look at an example of left ventricular hypertrophy. Look at lead 1. You can see that the QRS is upright and then it has kind of a flat or a slightly downsloping ST depression. You can see the same thing in lead AVL, V5, and V6. And this historically used to be called LVH with strain, but there's actually no strain on the heart going on here. It's just a function that a ventricle has gotten very big and it's taken it a good amount of time to depolarize the entire thing. And again, by the time that the outer layers of the ventricle are still depolarizing, the inners are starting to repolarize, leading to QRS to ST discordance. This is an example of a left bundle branch block, and you can see that these effects are much more pronounced and they apply to every single lead. So again, look at lead 1, QRS is upright and the ST segment is depressed. Same in lead AVL. And then if you look at the precordial leads, so lead V1, QRS is downright and the ST segment is upright. And the same thing in leads V2, V3, AVF, and 3. And as we said before, this is one of the defining characteristics of the left bundle branch block. So let's look at an example of a right bundle. You will see the same pattern repeating itself, but mostly in the leads that are looking at a right ventricle. Now in this particular RBB, the morphology is very pronounced. It goes all the way to V4, but in V1, V2, V3, V4, you can see a clear pattern of an upright QRS followed by a downsloping ST depression, essentially, and then it's far less pronounced in all the other leads because the RBB, if you'll remember, only affects the leads that look directly at the right ventricle. There is another thing we should know about the ST wave depression is there are four patterns of depression, and the first one is not so much depression but just the flipping of the T waves. And afterwards, if we have true depression, it could be upsloping, it could be flat, or the downsloping, and this relates to how the ST segment looks like. So if you look at the flipped T's, first thing to know is that they can be normal. Uh, in lead AVR and V1, flipped T's are always normal because those waves in a normal heart are generally negative, and if the QRS and ST segments are concordant, as is normal, that means that the ST segments will be negative as well. If you see flipped T waves in the other leads, then you have to think a little bit harder. Now, what do flip T waves mean? Well, quite honestly, they can mean anything. They could be a sign of an acute MI or a heart strain or an old MI or an old non-MI scar like myocarditis, or they could be simply there because of infiltration and old age. Similarly, young children all have flip T's and they all revert upright over time. So basically it's a non-specific sign. So you really have to look at the clinical context if it means something or not, and always compare it to the previous EKGs. So this is from a textbook on stress test interpretation. This is what cardiologists use to interpret changes during a stress test. So again, you'll see that if you have an ST depression that's upsloping, that sometimes means bad things, but not always. However, if you have an ST depression where the ST segment remains depressed and flat, or it's downsloping, that is considered bad and signs of ischemia. However, you have to remember that all of this is not true if conduction blocks or hypertrophy exist, because the presence of a left bundle or a right bundle or LV age may produce downsloping or flat ST depressions. So you really have to be looking for ST depressions that don't fit those patterns or are particularly pronounced. So this is an example again of left ventricular hypertrophy, and again look at leads 1 AVL, V5, V6. You will see that there are downsloping ST depressions, but they are appropriately discordant with the upright QRSs. So we really can't tell much more from the EKG except that a person has changes consistent with LV age. And how to tell if there is ischemia in the presence of LVH or other conduction problems we will cover a little bit later. Also remember that the ST depressions could be simply mirror image reciprocal changes of an ST elevation in the other leads. And the territories that mirror each other are inferior and lateral, and then anterior and posterior. So let's look at this person having a STEMI. If you look at the anterior leads, V1, V2, V3, up to V4, there is clear ST segment elevation. Well, what is the reciprocal territory to the anterior leads? It would be the posterior leads, which we don't routinely get unless we get a 15 lead ECG. So if we did a 15 lead, we can expect to see ST depressions there. We can also look lateral leads, so leads 1 and AVL, they have significant ST elevations as well. Well, what is the mirror image of the lateral leads is the inferior leads. So in the leads 2, 3, and AVF, you see significant ST depressions mirroring the ST elevations laterally. Finally, if you have a patient who's in digoxin, the presence of digoxin will frequently induce ST depressions of a particular type. They're colloquially known as a scooped ice cream ST depressions because they look like somebody has taken a scoop of ice cream out of that flat ECG line. So they're either hockey stick or biphasic ST depressions, and they don't mean that a person is toxic or anything like that. They just mean that a person is on digoxin, and it makes our job of interpreting ST segments tougher. So this is your ST depression checklist. When you see an ST depression, the first thing would be to determine if there's any hypertrophy or conduction block. And this is the reason why we do ST segment interpretation at the very end of an ECG interpretation. We need to know all the preceding things to do this accurately. And if there is any hypertrophy or conduction blocks, then we would expect to see appropriate discordance in the appropriate leads. The second thing to check when you see an ST depression is this simply a mirror image of an ST elevation somewhere else? And there are certain leads that are mirror images to each other. For example, AVL, which looks left and up, and lead 3, which looks right and down. And we'll cover this in more detail when we get to ST elevations. Third question to ask is, are there any weird morphologies? So again, big positive deflection after the ST depression, or that kind of ice cream scoop, in which case you start thinking about digoxin or hypokalemia. And if you don't see any of these preceding things, then we might start thinking that this is true ischemic change that has not caused an ST elevation. And also, just a little note, if you have somebody who is in a tachyarrhythmia of some kind, so an SVT or AFib or a flutter, feel free to ignore the ST depressions. They're usually because of the rate. The QRSs are spaced so closely together, it doesn't allow the ST segment to go back to normal. So the appropriate thing to do is to slow them down and then see how the ST segment looks like, rather than assume that there is ischemia right off the bat. When in doubt, look for things that don't fit. So if you, for example, have LVH and LBB and you see concordant ST changes, so an upright QRS with ST elevations or a downright QRS with ST depressions, that is a problem. That shouldn't be like that, and it should raise your eyebrows. Second is, look for excessive discordance. So if, for example, you have a left bundle and you have an upright QRS and the ST segment is very, very negative, the cutoff is more than 20% of the height of the QRS, then you can say, okay, this is probably ischemic. Always, if available, compared to previous, take serial EKGs, and when in doubt, err on the side of the more lethal diagnosis. ST elevation also has its checklist. And just like in ST depression, the first job would be to do the analysis for hypertrophy and block, because they can lead to discordant, appropriately discordant ST elevations. And then there are two more benign conditions that outside of a STEMI that cause ST elevations. The first one is benign early repolarization, then pericarditis, and finally ST elevation MI. This is an example of a left bundle. So if you look at the precordial leads, V1, V2, V3, V4, you can see that there are ST elevations there, right? The J point is elevated compared to the following T2P interval, which is a little bit tough to assess due to the irregularity and the fast heart rate, but it is elevated. However, it is appropriately discordant to the negative QRSs, and it is not excessive, which is to say the J point elevation is less than 20% of the height of the QRS, and therefore these are non-pathological. So conductions problem will create this issue of identifying accurately ST elevations. And in clinical practice, I would say that a left bundle is by far the most common reason, with paced rhythm being a distant second. In those conditions, the ST is always discordant, and in the precordial leads, which are negative, the ST segment will be elevated. Now, in the previous iterations of the American Heart Association guidelines, a new left bundle in the presence of chest pain was assumed to be a STEMI. Once this was studied, it turned out that about 16%, so 1 in 6 of these people actually did turn out to be a STEMI, so they have now pulled back from calling it an automatic STEMI. It just makes it tougher to tell. So what you have to do is, again, do all the other good care, do serial troponins, do serial ECGs, take a good history, bedside ultrasound, all these kind of things. And finally, use the modified Scarboza criteria, which is what we have covered in the previous slide, looking for inappropriate concordance or excessive discordance. So this is an example of STEMI in the presence of a left bundle. Look at the lead 3, for example. That's a very good example of inappropriate concordance. The QRS is upright in the presence of a left bundle. That should mean that the ST segment should be negative. However, it is elevated here. Again, look at lead AVL. It is negative. That means that the ST segment should be positive, and in fact, it's depressed. So again, it's inappropriately concordant. Finally, look at lead V3. You can see that a J point is quite elevated by about 6 or 7 millimeters, and if you map it out to the height of the QRS, it actually turns out to be more than 20% of the height of the QRS, so it is excessive discordance. Therefore, it's also pathological. And again, ST segment depression or elevation higher than 20% of the preceding QRS complex. Moving on to benign early repolarization. It's most prominent in young, fit, healthy people and at low heart rates. And the things that define it is minimal ST elevations, mostly in leads V2 to V5 with a concave morphology. So morphology you can draw a smiley face on. And then more rarely, and like in this example, you will have minimal, usually sub-millimeter ST elevations in inferior leads, so 2, 3, and AVF. So again, concave morphology, you should be able to draw a smiley face through the anterior lead, which has BER. So again, young healthy people, more prominent with slow heart rate. There is a low amount of ST elevations. It's mostly in the anterior chest leads, and there is no reciprocal changes. So if all of these things fit, then you can send these people home without any particular testing. It's a harmless condition. However, if you do have a doubt, either on account of the story or the risk factors or previous history, it's safer to assume an MI. So let's look at this example of pericarditis now. You will see there are ST elevations everywhere, and they don't follow the mirror image rules and the territories. So let's start with lateral leads. We'll see there is ST elevations in 1, AVL, V5, V6. So normally we should expect to see ST depressions as mirror images in the inferior leads, but if you look at the leads 2 and AVF, they actually have ST elevations as well, more so in 2 than AVF. And then also there are ST elevations in the precordial anterior leads, like V1 to V4. On top of that, we have PR depressions, which is pathognomic for pericarditis. So how do we diagnose it again? ST elevations everywhere. They're concave, like in benign early repolarization. There are no reciprocal ST depressions. The PR segment is depressed, and often these patients are young and they don't look particularly sick despite these impressive changes and sometimes very impressive troponins. So before we go into the ST elevations, let's take a quick look at the blood supply of the heart. So we're going to focus on the left side first, and on the left side, the left main splits into 2 arteries. The circumflex, which goes laterally and then curves behind and meets the right coronary artery and the posterior wall. And then we have the left anterior descending, which shoots across the surface of the left ventricle and then kind of curves backwards at the bottom of the heart. So the big picture is that the LAD occlusions tend to give us anterior MIs, and the circumflex occlusions give us lateral MIs, and sometimes those can extend into the posterior surface as well. So for the left-sided STEMIs, we have two major patterns. One is if we have a pure LAD occlusion, we'll usually have ST elevations in V1 to V4. Again, these are the anterior leads, so the reciprocal ST depressions would be on the posterior leads, which we don't routinely do, but if we did, we should see some ST depressions there. And then on the lateral side, um, or on the circumflex side, we have the lateral MI, so the ST elevations will be in the leads that look towards the lateral side um, on the left side of the heart, so leads 1, AVL, V5, and V6. And the reciprocal leads will be in the inferior leads. And the best way to think about it is think that lead AVL, that looks left and up, and lead 3, which looks right and down, are in fact true mirror image leads of each other because they're pointing in exactly the opposite directions. The other ones not so much, but the relationship holds up well enough that we can use it clinically. And again, that's a sign of a circumflex occlusion. However, in some patients, the circumflex, again, as it wraps around the back, in many patients, so in all the patients, it meets the right coronary artery, and in many patients, the right coronary artery is the dominant blood supply to the posterior wall, but not in all. Some people have the circumflex as the main supplier of the posterior wall, in which case we'll have the lateral with posterior involvement. So again, we'll have all the signs of the lateral MI. We'll have the ST elevations in the lateral leads, reciprocal ST depressions in the inferior leads. But on top of that, we'll have an ST elevations in the posterior leads, which again, we don't routinely do. So what we'll see is we'll see the mirror image ST depressions anteriorly in the leads V1 to V4. So this is an example of a predominantly anterior MI. So if we look at leads V1 to V4, we see very prominent and large ST elevations. Now again, as we mentioned, the mirror image of the anterior field would be in the back. So the posterior leads, which we don't routinely do, but if we did a 15 lead, we would expect to see some ST depressions there. In addition to this, we can also see some minimal ST elevations in leads 1 and AVL, and then some mirror image ST depressions in the inferior leads, so 2, 3, and AVF. So this confirms that there's two territories involved here. So the anterior is the primary one, and then the lateral is involved as well. So this is probably a person with a very proximal LAD occlusion or an occlusion somewhere close to where the LAD and the circumflex bifurcate. This is a very, very significant ST elevation. So the anterior STEMIs, including especially the proximal LAD, are the biggest widow makers of the acute coronary occlusion world. They have the highest incidence of death, the highest incidence of going into ventricular fibrillation and ventricular tachycardia, and they have the highest chance of going into cardiogenic shock. And given that there's two territories involved here, that indicates that the myocardium at risk is even larger, and therefore all the downrights or downstream sequelae are even more likely. So this is somebody who has a very high chance of having a bad outcome from this acute occlusion. Looking at this ECG, we'll notice quickly that there are very significant ST elevations on the lateral side. So leads 1, AVL, a little bit less pronounced in the V5, V6. And then there are reciprocal ST depressions in 2, 3, and AVF, which all fits with a lateral MI. However, if we take a careful look at the anterior leads, so V1, V2, V3, we'll see there are some ST depressions there. So that raises the possibility that this is in fact a lateral MI with posterior involvement, and these ST depressions are mirror images of the ST elevations that we would see if we did a 15 lead ECG, as we discussed in the previous slide. Now let's look at the right side of the heart. So you will see that the RCA comes off from the aorta and then comes on top of the RV. Remember that the RV sits in front of the LV, kind of bulges towards the chest wall, and in most people it's supplied by the RCA. And then after supplying the right ventricle, the right coronary artery curves behind the heart and supplies the back, the posterior portion of the heart, and then it goes inferiorly towards the tip and meets the LAD at the bottom, and it supplies the inferior portion of the heart in about 80% of the people. So the pattern of ST elevations with STEMIs that occur due to occlusion on the right coronary artery depends on how distal the occlusion is. We'll start with the most distal one because it's the simplest, and as we saw in the previous slide, at a very distal tip, the RCA supplies the inferior portion, the bottom of the heart. So the leads that look inferiorly will have ST elevations. So that's 2, 3, and AVF. And the leads that look kind of towards the top of the heart, which is the lateral leads more or less, will produce reciprocal ST depressions. Now, if you have a mid-level RCA occlusion, remembering at that point the RCA has kind of curved behind the heart, supplying the posterior wall of the heart, and then everything distal to it, ending up with the inferior portion of the heart. And if you have an occlusion there, you will occlude everything distal to the occlusion. So you normally have the inferior STEMI pattern. So again, ST elevations in 2, 3, and AVF, and ST depressions in 1 and AVL, maybe V5, V6. However, now we have to also add the posterior ischemia. Now, what leads look posteriorly? Well, none of them do, unless we do a 15 lead ECG. So if you have just a 12 lead ECG, you will not see the posterior ST elevations. What you will see is the mirror images, the ST depressions in the anterior leads. So an inferior with a posterior, which again is a mid-level RCA infarct, will look like an inferior MI with anterior ST depressions. Finally, if you have a very proximal RCA infarct, remember again that a very proximal part of the RCA supplies the right ventricle first and then everything distal to it. So again, you should see inferior changes, 2, 3 in AVF elevated, 1 AVL depressed, but then you should also see signs of RV infarct. And again, remember the leads V1 and V2, they're looking directly at the RV, so those are the ones in which you should see ST elevations on top of the inferior injury pattern. Also, because lead 3 is the one that looks more towards the right side of the heart, it looks right and down, if you remember, is the most sensitive of the 3 inferior leads to changes on the right side of the heart and the right ventricle. The ST elevation in lead 3 should be bigger than in either lead 2 or AVF. Now at this point you might be rightfully confused as to why is V1, V2 signifying a right ventricular infarct, whether we previously discussed that kind of V1 to V4 are signs of LAD occlusion, and usually V1 and V2 are seen as septal leads. However, this is just an artifact of ECG being a 2D representation of a 3-dimensional structure. So in fact, if you remember from the beginning of the course, the RV sits in front of the LV and specifically in front of the septum. So when the leads V1 and V2 depolarize and repolarize, the first thing that they detect is what the RV is doing, and then after that they detect what the septum, which is directly behind the RV, is doing. So really those two leads are a superimposition of two separate structures, and it just depends which one of them is being hurt at this particular time, which will result in the ST segment changes. So here are some examples. This is an inferior posterior MI. You can see the classical inferior ST elevations, 2, 3, and AVF. You can see the mirror image ST depressions in 1 and AVL, and to some degree in V5 and maybe V4. But then if you look at the anterior precordial leads, V1, V2, V3, you see that I have ST depressions, which are in this case caused by ST elevations posteriorly, which we will not see unless we do a 15-lead ECG. So again, posterior inferior MI, mid RCA, STEMI inferiorly, reciprocal ST depressions laterally, and then ST depressions anteriorly. And if we were to do a 15-lead ECG on one of these guys, it's another example, but it follows a similar pattern. Again, 2, 3, and AVF have ST elevations, and then V1, V2, V3 have ST depressions. If you do a 15-lead, you see that all three of the posterior leads are significantly elevated. This is an example of an inferior MI with RV involvement. So again, this would be the very proximal RCA occlusion. So again, you can see elevations in 2, 3, and AVF, reciprocal ST depressions in 1, AVL, and V6, and a little bit in V5. And if we look at a precordial anterior leads, we see anterior ST elevations in V1, V2, to less degree V3. So those are the leads that look at the RV, which is overlaying in front of the LV and bulging towards the chest wall. Also, looking at the amount of ST elevations in the inferior leads, you will see the lead 3, which again looks down and right and is thus more sensitive to the changes in the right ventricle, is significantly more ST elevated than the other two inferior leads. So again, inferior with RV involvement, ST elevations in V1 to V3, ST elevations inferiorly, and the ST elevation is 3 is larger than in the other inferior leads. Why this matters is because these types of MIs are very preload dependent. Remember that the right side of the heart is our low pressure system. And the RV is not as strong as the LV. So if we drop the preload in a person who has infarcted the weak muscle of the RV, the remaining muscle will not be strong to push the fluid into the lung circulation. So we should be avoiding preload reducers like nitroglycerin and morphine and Lasix in these patients. Fentanyl is our friend. And then if these patients are hypotensive, we should give them fluids, assuming they don't have any signs of acute CHF that we can't deal with. And again, just to recap, the very distal RCA will simply give you an inferior MI. A more proximal occlusion will give you inferior with a posterior, and then a more proximal still will give you inferior with the RV infarct. And these are the classical changes you will see with that. So this is your final global ST elevation checklist. First, is there any bundle branch blocks or hypertrophy which could account for these ST elevations appropriately? Is it benign early repolarization by history and by EKG? If not, does it follow a particular territory? And if none of the above is the case and the ST elevations are everywhere, it is likely pericarditis. And quick reminders, LV age and conduction problems will cause QRS to ST discordance, which again means they will be pointing in the opposite directions. In the absence of LV age and conduction problems, if you see downsloping or horizontal ST depressions, those are bad. If you do have LV age and conduction problems, look for inappropriate concordance, so QRS and ST pointing in the same direction, or excessive discordance, so again pointing in the opposite directions, but a degree of ST depression or ST elevation is more than 20% of the height of the preceding QRS. In ST elevations, look for reciprocal changes to help you define the territory. And if you do see concave ST elevations, it is more likely to be benign early repolarization and pericarditis. If you see convex or horizontal, that is more likely to be a STEMI. Thanks for listening, and we'll see you in the course.